We please proceed with the first session of our today, which is on corrosive injury. And for our session, our chairpersons are Dr. Ramkrishna Prabhu, Dr. Anil Agarwal, Dr. Sundeep Jain, and Dr. Govind Nandkumar. And from here, I am handing over the session to our chairpersons.
Hi, good morning, everybody. Thank you for being here early in the morning. And we have an interesting session on corrosive injury of the esophagus. And our first speaker doesn't need much of an introduction, Dr. Inian, well known in the field. And he'll speak to us about a difficult corrosive stricture patient preoperative evaluation. Thank you, Dr. Inian.
Respected chairpersons, senior colleagues, and friends. At the outset, I'd like to thank the organizers for the invitation and for the opportunity. So my brief is to talk on difficult corrosive strictures. How do you evaluate these patients preoperatively, and the difficult decision makings, etc., regarding this patient. And I bring along with me greetings from our hospital in Vellore. So there cannot be a corrosive stricture talk or a session without remembering Professor Chandra Mohan. So we fondly remember him and deeply miss him too. Now, we know that corrosive injuries of the upper GI tract are a source of considerable morbidity. Now, these are young patients. The magnitude of the injury depends on various things such as the nature, the volume, concentration, etc. So when we deal with chronic corrosive injuries, basically a good history and physical examination is crucial. Nutritional assessment, and needless to say, psychological assessment forms a major part of the assessment prior to definitive surgery. So generally, at least 6 months is necessary to allow time for remodeling and stabilization of these strictures. I'm not going to go into the details of the conduit use, so depending on what is being planned, you need to investigate on these as well. Yesterday we saw beautiful videos on minimally invasive procedures for this being done. So that is possible with good outcomes. And of course, nutritional rehabilitation in the form of a feeding procedure is of prime importance while we wait for definitive surgery. So in this talk, I'll be mainly talking about the difficult one, which is the high or the pharyngoesophageal strictures. Now, why is it difficult? This is because of the site of involvement and its possible association with laryngeal injuries as well. Now, these pose quite difficult problems, both pre, intra-op, and post-op. Now, these kind of strictures comprise of around more than 1/3 or 1/4 of all the corrosive injuries, so they're not uncommon. And they're difficult because of the proximal location, as I said, the associated laryngeal injury, and the presence of downstream strictures. Basically, now these downstream strictures cannot be assessed because of the proximal nature of the main stricture. And therefore, needless to say, require considerable planning, expertise, and multidisciplinary management. So to provide a roadmap, this is the study that is an upper GI study. A thin barium is used rather than gastrographin, as we all know. Now, if you look at the picture on the right, if it's a very high stricture and the patient is not able to swallow, this test may not be very useful. An upper GI scopy, definitely to look at the stricture, delineate the stricture, locate it, and also to assess the mucosa proximal to the stricture, because that's where the anastomosis is going to happen. A proper ENT assessment is crucial, a video laryngoscopy, and if there is significant injury like this, then one needs to also look at doing an ENT procedure like, excision of scar tissue, etc. And also look at the need for a tracheostomy. Now, this tracheostomy can be even permanent. And many of these patients with proximal injuries already have a tracheostomy. If the barium study looks like this, then most likely this is aspiration. However, one also needs to consider the rare association of tracheoesophageal fistulas. So therefore, a bronchoscopy may be necessary in the pre-op evaluation. So what does one do if you cannot get a barium study? Sometimes CT scan, after asking the patient to swallow air, can be useful. Now, as in this patient, this is a proximal stricture which starts at the cricopharyngeal area. And as we go down, you can start seeing the esophagus, which is here. So obviously there is some lumen in the of the esophagus, which is still there in the cervical esophagus. What about endoscopic ultrasound? Perhaps useful in acute setting, but in chronic strictures assessment, perhaps not a big role or no role. Of course, a barium enema or a colonoscopy if you're contemplating colon as the conduit. One doesn't need to do a mesenteric angiography routinely. We had discussed earlier, if you're doing a minimally invasive procedure, perhaps you don't want to miss a vascular anomaly. But otherwise, generally it is only done in patients who have had failed previous attempts at surgery or prior resection of colon, etc., or in elderly and patients with peripheral vascular disease. So it's not routinely necessary. But of course, if you're thinking of doing supercharging, which is basically enhancing the vascularity of the conduit, then you need to do an angiogram. We've talked about nutritional rehabilitation. Preoperative enteral feeding is commenced. And of course, mechanical bowel preparation, because we will probably most likely be using colon. Now, this is a fantastic article from Professor Ananthakrishnan, Dr. Vikram Kate and team from JIPMAR. Basically, their experience in dealing with these complex pharyngoesophageal corrosive strictures. We've also published our data regarding the management of this problem earlier. So basically, it comes down to the procedure as far as doing the anastomosis in the pharynx versus doing the anastomosis in the esophagus. Far superior results with esophagocoloplasty. Now, if the anastomosis is done more proximal to this, that is, if it is a pharyngocoloplasty, significant swallowing problems, aspiration, etc. So whenever possible, it's advisable to widen the pharyngoesophageal junction and do the anastomosis lower down in the esophagus. So coming back to this pharyngoesophageal strictures, now these can be either focal or this could be a longer stricture, but at least you are able to see a demonstrable segment of cervical esophagus on a barium study. Or it could be a high stricture and no demonstrable lumen beyond the stricture. So if we divide these difficult strictures into these categories, so we'll take the first one, which is the focal stricture, but distal lumen is demonstrable. Now these are relatively easy. These can be dilated endoscopically, or perhaps you can look at a local flap, such as pectoralis major, sternomastoid, etc. Now, the second situation where you got a lengthy stricture, but you got a distal lumen that's demonstrable. So you may have to do a two-stage procedure, such as a cervical esophagostomy in the first place, dilate it, and then do the anastomosis lower down when the stricture is more stable. Or you can do a local flap and a staged procedure. Again, an esophagocoloplasty rather than a pharyngoplasty. Now, the most difficult of this is the third group where you do not see any lumen. So basically a high stricture, nothing in barium going down. The results are poor, and obviously there is risk of aspiration, so tracheostomy necessary. And more importantly, the esophagus and stomach distal to the stricture cannot be assessed preoperatively properly. So what do you do for this situation? So you can do an initial neck exploration, and if the lumen is identified, then you can do a two-stage procedure, basically a local flap to stabilize the lumen, and a second stage procedure, which is a esophagocoloplasty. Now, if on initial neck exploration there is no lumen at all, then you need to see whether the larynx is salvageable and with minimal involvement, in which case you can do a pharyngocoloplasty with a tracheostomy. Or if there's extensive laryngeal involvement, then you will be looking at a permanent tracheostomy or a feeding jejunostomy alone. Now this is one of our patients recently, young patient, very high stricture, nothing going down basically at the pharyngoesophageal junction, couldn't do a barium. When we did a CT scan, there was possibility of a lumen in the cervical esophagus. So basically, we explored the left neck, so you can see that's the stricture which has been opened out, so that's the strictured area. This is the esophagus lower down, which seemed to be all right. There was lumen available in this patient. So therefore, we did a sternomastoid flap with a skin paddle. So you just, this is the sternomastoid with a skin paddle turned inside, which is sutured to the strictured area of the esophagus. So that's one wall completed, and this is sutured to the other wall here, and that's the completed flap. And post-operatively, this is a picture. You can see the barium going down. Now, this patient had a more distal stricture as well, so we had to deal with this in the second sitting. So this is the endoscopy for this patient. This is a skin paddle which was put in, and this stricture was stabilized, but more distally had a very tight stricture. So we had to do for this patient, we did an esophageal resection, colonic conduit, and an anastomosis on the opposite side of the neck. So to conclude, high pharyngeal strictures require considerable expertise in management. Good preoperative evaluation of the pharynx and larynx is mandatory. A flexible, tailored approach for every patient. Generally, the post-operative course is protracted and therefore requires a multidisciplinary team effort. Thank you for your kind attention. This is our new campus in CMC Vellore.
Thank you, Dr. Inian. We have time, so I have one question to start, and then we can take questions. What about in the preoperative evaluation? My limited experience in this condition is that there is a tremendous amount of psychosocial counseling that has to go through and be part of the whole process. How do you incorporate that in your pre-op evaluation?
Yeah, you're right. Basically, these are young patients. Obviously, most of these are suicidal in nature. So we definitely get a psychological assessment that forms one of the initial things before we even contemplate any surgery. So that being done, and that happens over the period of the preoperative evaluation. So that happens simultaneously. Usually, it's an impulsive thing. Most of the time, people just do it because, So they don't have, major psychological issues, but they definitely require counseling. So you're definitely right. We do that.
Good morning.
Yes, Steve.
Inian, absolutely superb talk. There is so much wisdom thrown in 12 minutes. I've not seen that many times. I've got two specific questions. One is regarding use of stent to stabilize the covered stent to stabilize the stricture before you start doing reconstruction, because that's what we do. We don't do that many in the UK, but when we do, we tend to do that. We don't see strictures of this sort, that what you saw, that there are not many in number. So that's number one. And the second question, you did mention esophagectomy. And my question is, in your experience, how tough this is going into the chest and taking it out? I've got a patient where I'm planning to do that. So I need your experience and your assurance on that. Thank you.
Yeah. Thanks, Deep. So regarding your first question on stents, generally, it depends on the location of the stricture. Now, if you got very high strictures like that, that's out of question. Now, to stabilize the stricture during the phase where you're waiting for surgery, or when dilatation happens, it's possible to put a removable stent. In fact, unfortunately, we've had a couple of instances where they put partially covered stents and the whole thing became incorporated. And in fact, we had to do an esophagectomy for a couple of, actually 3 patients in the last maybe 5 years, just because a stent was put. So one needs to be very careful. Obviously, you can put a stent as a temporary measure. Most of the time, it will need something more definitive. So dilatation and stenting possible. There are, dissolvable stents, or stents which so you can put it in and then sort of go away, but it's not in commercial use. So generally speaking, high strictures no, and for other strictures you can put a stent in the interim. Obviously not very useful for very tight strictures. Regarding the second part of the question, firstly, whether esophagectomy is necessary. The very small chance of malignancy, so although there is a very small chance, it's not necessary to do an esophagectomy because the incidence is very small. Now, is it safe to do it? It really depends on the location as well. Generally, the ones that we have done are lower strictures away from the airway. There is, the ones that we don't do it on a regular basis. This was one of the few that we did actually do it. But generally speaking, there will be some periesophageal, fibrosis. And if it is in relation to the airway, we don't really attempt it. So it's only for lower strictures we do attempt this, if at all we do it. But the best, the conduit, basically once you do an esophagectomy, the conduit can be in the posterior mediastinum. So that is the shortest route and that's the best route. So, if it's lower down, young patient, perhaps we have tried that. Yeah.
Yeah, so
After you.
a good talk. I really enjoyed it.
Thank you.
Yeah, the upper strictures are the real problems and quite unsatisfactory at times. Our experience is also same. Tried a lot of multidisciplinary managements, plastic surgeries, and many things. But ultimately, as you rightly said, try to dilate it as much as possible and avoid an aspiration by anastomosing it slightly below.
Lower down.
And this dilatation is also on the table. When you find it, strictured, even with the Hagar's dilators, you are able to dilate to a significant level. And then follow it up with a self-dilatation by the patient himself, because they would invariably get strictured, and you teach them how to dilate with a Foley's catheter, a balloon Foley's, and some of them have managed very well. They develop the trick. Once they are involved in that, they develop the trick and they do well. We have given up most of the reconstructive or plastic procedures there because they were quite unsatisfactory. And if it's beyond, say it's all of rosenpharynx, the epiglottis stuck, and then we just give the option to the patient. Either you swallow or you speak, not both. And then probably anastomose it to the floor of the mouth, and they do very well, and they are quite happy eating. The second thing about the resection. Esophageal resection for a corrosive stricture, it's not we have done, but not for preventing malignancy, but the strictures in the lower end, long strictures in the lower end, but fairly normal esophagus up.
Correct.
See, when you try to bypass this, they would tend to develop a large mucocele of the esophagus, and that could be quite a problem. We had instances of at least 3 or 4 cases of big mucoceles had to tackle. So in such cases, you invariably offer a transhiatal resection. And transhiatal resection for a lower end stricture is not a big issue. If the stricture is deep and critical, and at the carina, sometimes it can be a problem because of the periesophageal inflammation. But by and large, when you wait long enough, say 4 or 5 months or 6 months, it is not a problem doing a transhiatal esophagectomy for these patients.
Yes, thank you. And one more thing, just to add on to what you just said. In addition to this thing. It can form like a sump. The mucocele is one, and then, very low down, you try to do an anastomosis higher up. This segment of normal esophagus in the chest just acts like a sump. So again, they regurgitate all these issues. So, yeah.
Morning, sir.
Please.
Sir, morning, sir.
Yes.
This is Brigadier Banerjee. I am Sarang Bharti from the same team. We have had some experience with dealing with these kind of strictures. There are 3 or 4 points that I thought I should share.
Sure.
One of the things which you mentioned was it is completely obliterated. So sometimes what happens is it is obliterated at the upper, and lower down it's just a very thin streak in which you can, if you use an endoscope, and it gets transluminated, and then that part can be perforated. So instead of doing 2 procedures in which you put a PMC flap, and later down you realize there are multiple other things and you have to do it again, we prefer to take a colon, do a side-to-side anastomosis in such a way that now it becomes a bigger hole, open it longitudinally and attached sideways. So it acts as a neat bypass procedure, and that can be done minimally invasively. The second point is, as regards sump of the esophagus that is left behind. So the patient, when they come to us, they are already in a very nutritionally compromised state. We've just been able to get them over to albumin of 3 or something with great difficulty. And if you have esophageal resection at that time, it's better to postpone it for a few months. And if it is really causing a problem, then minimally invasive procedure, and wherever it is very badly stuck, that part can be omitted. And if you are able to put a stapler above, that part can be omitted and left behind. It doesn't cause any problem. The third point which we felt was, if you have a larynx and a patent pariform fossa, even if you do a partial laryngectomy and put the ileum matches it perfectly, and only thing is they require a bit of swallowing education after some time. So they also do well. So these are some of the points I thought I should share.
Yeah, absolutely.
Just to add one more thing here, Dr. Prabhu here, Inian. Just to add one more thing, at our institute we have quite a few experience of managing these pharyngoesophageal strictures.
Sure.
In this patient, we do a esophagostomy and pass an endless string. And like Dr. Shastri said, initially we do it under anesthesia, dilatation of the stricture. And once it has stabilized, we tend to do anastomosis at the esophagus and avoiding the pharynx.
So basically
that plays
2-stage procedure.
Yeah, 2-stage. It plays a very good thing because it gives you time, nutrition, you can build up the patient and helps the patient in the long run, both for speaking as well as for swallowing.
Yeah, sure.
Last question.
So this is just information with due respect to Professor Shastri, who is a pioneer in corrosive management. We in AIMS Delhi, we have been doing a randomized trial since 2012. It's completing now comparison between resection and bypass, and to see the intraoperative and immediate post-operative complications. So we have finished 40 in each arms and not a single injury. But we have to modify a lot of things. Though we started it in 1992, over experience we thought we could be able to do it, and it can be done. It can be done safely, but trainings are required.
So one question. Thank you. So just regarding the point that sir pointed out regarding mucocele forming in the remnant esophagus, what is your take on the option of draining the native esophagus into a loop of jejunum rather than going for an esophagectomy in this? Because we've also seen a couple of cases of mucocele forming lower down the line.
Yeah. So basically, it really depends on, if you have a stricture, a long stricture of the esophagus, okay, you have the stomach, right? Which is still attached. Now, if you're going to remove the stomach for some reason, like for example, if the stomach is also involved, or if it's this thing, then you obviously will do a drainage procedure, an esophagojejunostomy there. Now, your question is, if you're doing a proximal anastomosis, there is a stricture, and then
there's a normal part of esophagus.
Normal part of esophagus, and then there is another stricture lower down. That's what you're.
No, so no another stricture.
Okay.
There is a normal part of esophagus which is left.
Yeah.
There's a stricture
so
above.
If you're using colon as the conduit, now that anyway is attached to the to the stomach, and that should drain. Now it's only when you're doing a resection that this kind of thing you need to decide upon. I hope I'm clear about.
I think we'll stop over here. We'll go to the next talk because we are running short of time, and this discussion will continue if we have some time after all 3 presentations. Thank you, Dr.
Thank you.
Inian.
Thank you, Dr. Inian.